Thank you very much.
Thank you very much, Dr. Tayyab. You brought in a great subject. It's immensely important. A lot of my younger colleagues, they have to spend many years and they should be practicing these things right now because it's essentially very, very important. In fact, I had a chance to go to IAEA headquarters. I represented Atomic Energy Commission, and there they were talking of the hazards of radiation in the cath lab. And in 2 days' time, I saw horrible pictures affected by radiation and a lot of things they talked about, and I am really scared. Thank you.
Are these real-time monitors available in Pakistan?
No.
That's very important. I think you and they put two, yes, one under that lead and one over the lead,
And
outside
check it.
lead. So this is really very important.
And check the radiations frequently.
It's always better. I think the badges are lying somewhere else, and you
Yeah.
put on the tent, and then you're very happy to put your foot on the fluoroscopy, and then.
भूल जाने के बाद।
और बिल्कुल exactly ये वाली चीज़ है. Yeah.
Huh?
That's it. I think especially a caution for the operators who are doing the CTOs, or especially kind of radiation you got. That's really awesome. One has to be very, very careful. That's why I have stopped doing the CTOs.
Life saving.
Let other people do.
So finally we are successful, and we'll talk about now wires. Coronary guide wires are used to track through the vessel, access the lesion, cross it atraumatically, steer into or away from side branches, provide device delivery support, and unhindered device movement. Optimal wire selection may make the difference between procedural success and failure. And coronary guide wire is considered the master key to all locks. The coronary guide wire has got basically three parts: the central core, then outer covering. They can be either metal coils or they can be polymer. These are known as plastic wire. They are basically hydrophilic. The metal coil wires give you better tactile feedback. And then there is a flexible distal tip, which can be with spring coil from 1 to 25 millimeters. And there is a very short distal tip weld, and they can either be a core to tip design or a shaping ribbon design. We talk about why they can be, if the tip load is generally less than 1 gram, we call them as soft wires like BMW, Run Through, Sion, Cougar XT. And intermediate tip can be from 1 to 4 grams. The examples are Pilot 50, 150, and Gaia First. And anything more than 5 grams, 4 grams is considered a stiff wire. Examples are Miracle, 6, 9, Conquest Pro, etc. Now, how do you shape the wire with generally with a needle? Roll the needle on the distal part and make a 45 degrees J band, that is known as a Workhorse band. Or for the CTOs, you give a very small band, 1 millimeter from the distal end, and with 45 degrees. The best example is a Gaia second wire, which comes with the free pre-formed band. Now, basic tips: wire advance gently and should pass smoothly. There should be withdrawal and reorientation if there is buckling. It should not be forcefully jammed because it can disrupt the plug and cause thrombus formation, which can lead to acute vessel closure. One should repeated clock and counter and clockwise rotation of 180 degrees helps in smooth progression after you have crossed the lesion. One should not rotate the wire to 360 degrees continuously because it can get trapped into a small branch and tip can get fractured, or there can be damage to the wire. One should try and place the wire as distally as possible, but should not hit the end of the vessel. Now, this was the left main ostial lesion. You can see a very, very tight lesion. Already the blood flow is reduced. Probably the diagnostic angio has got disrupted the plaque. You need a very soft wire which would get through this area atraumatically. And the wire we use for this lesion was a BMW wire, which has got a tip load of 0.6 gram only. And that is the final result. And these are the features of the BMW wire. Now, this is another case of acute coronary syndrome. This is a large thrombus burden. RC is totally occluded. Again, this was acute coronary syndrome. The thrombus is very soft. It's generally wise to pick up a soft wire or Workhorse wire. In this particular patient, we used a Sion wire from Asai. It has got a tip load of 0.7 grams. It provides medium support, and that is the end result on the right side. These are the features of Xeon wire. You can see this, although it's a small wire, but there are about 6 or 7 structures inside the the wire. It is a lot of research and advanced scientific materials are used before the wires are made. Now, these workhorse wires, these are or the software wires like BMW, Xeon, run through are mostly used in our lab. This was 80% of lesions. They are used for type A, type B lesions, primary PCI, acute stent thrombosis, bifurcation lesions, recent occlusions, and they can be used as buddy wires, cutting wires, or anchor wires along with the balloons. And they generally are not suitable chronic total occlusions. Now, this is an example of a very tortuous RCA. You can see it's a shepherd crook RCA. On the right side, you can see an ambulance guide and a wire, but the lesion was used to cross with the run-through wire. But as soon as we tried to push the balloon, the guider got thrown out. It was again recrossed with the BMW wire, with the AL2 wire, and a support wire from Abbott Vascular Whisper ES was used. So you can use a support wire, then the procedure was completed easily. That was the final result. Now, bifurcation lesion wire tips. One should try and wire the difficult lesion first. One should try and wire the angulated lesion first. One should try and avoid 180-degree rotations to avoid wire entanglement. One should not remove the jailed wire before the side branch has been recrossed. And in case of wire wrap, withdraw the wire which is easy to rewire. Now, advantage of keeping a wire in the side branch, it keeps it open and makes recrossing easy by making the angle more favorable, serves as a marker in case of severe reduction of blood flow. If recrossing is not possible, a small balloon can be passed sub-stent to establish the blood flow, and then the balloon branch can be recrossed. Now, this is an example of bifurcation angioplasty. This was a tap technique. And you can see there is a tight lesion in both diagonal and LED. We use 2 run-through wires to do this procedure. Now, run-through is to remove frontline wire. It's particularly used for multiple interventions. It provides multiple lesion interventions or multiple artery interventions. It provides good conformability and trackability. And it has a dual core design. Shaft is stainless steel, and the distal core and shaping ribbon is of nitinol alloy, and it retains its shape. Distal part is a spring coil which has got a hydrophilic polymer coating. With distal 1 centimeter is shapeable. Then coming to subtotal total occlusions and chronic total occlusions, the technique to cross these lesions with wires is like sliding, drilling, and penetration. And there are 3 steps of crossing the CTO. First is the crossing the proximal tip, then navigating through the occlusion, then entry into the distal artery after getting through the distal cap. During the CTO angioplasty, one has used many wires, like getting the access to the lesion maybe with the workhorse wire. Then we have to use specialty wire with the use of a microcatheter. Like for puncturing, you may have to stiffer wire like a Conquest Pro or Gaia Second. Then through the CTO body, you can use a Pilot 200 or a Gaia Second. And then again, you have to use a soft wire to end up complete the procedure. And this process is known as escalation and de-escalation. Now, CTO antegrade. One should try and use to look at the lesion very carefully and see if there is a microchannel. If there is a microchannel, filter XT is a good wire. Even Gaia Second also can be used for microchannels. And if there is no microchannel, then you have to see whether the course of the vessel is known or not. If the course of the vessel is not known, then probably it's better to use a Pilot 200 wire, which is less likely to go subintimal. If the course of the vessel is known, then Gaia Second is the wire of choice. Now, this is a case. You can see there is an RCA. Mid, there is a coronary total occlusion. There are multiple bridging collaterals. And we, when very carefully looked at the lesion, we were able to see a microchannel. And we took a fielder XT for this wire, for this lesion. It's a plastic coated from Asai wire. Tip load is around about 1.42 grams. It is tapered for microchannels, and it just gets through the lesions very well. So this was the final views. Now, there is a subtotal occlusion. This lesion did not cross with the fielder XT, but was crossed with the Gaia Second wire. Next, that's the final result. Then Pilot 200, where the vessel not known, then you can use a Pilot 200 wire. Then we use a controlate injection to confirm that whether it is in the lumen or not. These are features of the 200 wire. You can also use a knuckle wire. It gives a big knuckle, which is less likely to go into the subintimal area. Now, for hybrid approach, when you have to do a retrograde approach, then you have to see the lesion very carefully. If there's a clear proximal cap, the lesion length is less than 20 millimeters, and there's a good distal vessel, then use an antegrade approach. Otherwise, you can try a retrograde approach. So he's standing next to me, so I have to hurry up. Closing remarks: place the wire as distally as possible for better support. Don't let the wire move forwards or get pulled once across the lesion. Keep the wire clean at all times, wipe it frequently. If there's a loop formation in the aorta, pull the guide catheter back and then push forward, pulling the wire at the same time. Avoid jailing the wire in calcific vessels at high pressure. Wire-induced perforations can be managed generally conservatively. Now, in the words of Charles Daughter and Melvin Judkins, the guide wire is passed across the atheromatous block without going through the wall, more by application of judgment rather than force. It's important for the operator to focus on the selected set of wires rather than trying to use all wires that are on the market at the same time. Thank you very much. I'm really thankful to you for your patience. Take it.
Thank you very much. Our last speaker is Dr. Jabbar Ali, and he'll talk about vascular access